Okay. So thank you very much for asking me to speak on the principles of post-traumatic deformity correction. I'll try and explain some basic principles that we use when we're planning deformity correction for trauma. So first of all, we have to identify our deformity and then identify which bone the deformity lies in. And that can sometimes be tricky. It's not always as straightforward as it may seem from x-rays or from clinical pictures. And then you have to decide whether it needs to be corrected or not, because not all deformities require correction. Once you've decided that you want to correct your deformity, then you need to decide where to make your osteotomy, how to correct it, and how to stabilize it. So we'll talk about each of those things in turn. So this is an algorithm that I learned from John Herzenberg from Baltimore, and it's a really good algorithm when it comes to planning deformity correction. And it's called MAP the ABCs. So MAP stands for measuring the mechanical axis, analyzing the joint angles, and then picking the deformed bone. And there may be more than one, of course. And then ABC is actually the technical aspect of what you're going to do. So determining where the apex of the deformity is, determining the level at which to make your osteotomy, and then deciding how you're going to achieve your correction. Is it going to be an acute correction or a gradual correction? And how you're going to stabilize it. So let's look at those. So first of all, identifying the deformity, you have to look at the mechanical axis of the lower limb. And particularly speaking about the lower limb, because we tend to do most of our deformity correction in the lower limb. And that is because deformity in the upper limb is more forgiving. So the mechanical axis is a line drawn from the center of rotation of the hip to the center of the ankle joint in a patient who is standing, where the X-ray beam is centered between the knees. And this is the mechanical axis of the limb, because this is the line through which weight falls. And in a normal patient, that line would normally fall either through the center or slightly medial in the knee joint. So, for example, you can see that drawing the mechanical axis on the X-rays on the right-hand side of the screen will show you that this patient's mechanical axis on the right lower limb is grossly deviated. Following drawing our mechanical axis, the next step is to analyze the joint angles. So the joints of the hip, the knee, and the ankle all have a range of normal angles, and you can see those angles in this picture. And so you need to know what the normal joint angles are before you can identify whether they're abnormal or not. And so it's quite important to determine whether the joint angles are normal, because if they're abnormal, that may indicate a deformity around the joint. So, for example, in the lower limb, we tend to use around the knee joint, we tend to use the lateral distal femoral angle and the medial proximal tibial angle for deformities around the knee joint. So this is an example of using those angles to pick which bone is deformed. So you can see here, the obvious deformity is in the left femur. But if you want to know where exactly the deformity lies, because you can see that the knee joint on the left is not exactly parallel to the floor, unlike the right side. So if you want to know where exactly in the femur your deformity is, you have to draw your angles. And you can see if you compare the joint angles on the right and on the left, there's a distinct difference in the proximal femoral angles between the two sides. And so if you draw out your joint angles, that will then show you the location of your deformity. And when it comes to measuring the mechanical axis in the femur and the tibia, in the tibia, the mechanical and the anatomical axis of the bone is roughly similar. there's a difference of about 3 degrees, but in the grand scheme of things, that is minimal. And so for practical purposes, you can assume that the mechanical and the anatomical axis in the tibia is the same. However, for the femur, there is quite a difference. So there is a difference of 5 to 7 degrees between the anatomical and the mechanical axis of the femur, because the anatomical axis of the femur is at an angle of about 5 to 7 degrees of valgus compared to the mechanical axis. So if you have a deformity in the femur, you may need to know what the true mechanical axis is. And there are 2 broad ways of measuring that. So if you look at the X-ray towards the left-hand side, you will see that the joint angles of the hip have been used to measure the mechanical axis of the femur. So if you draw out the joint lines, as we saw in our first image, then that will show you where the normal mechanical axis is supposed to be. And this tends to be more accurate if you are wanting to correct to a normal mechanical axis. The other way of determining the mechanical axis of the femur is on the right-hand side. And there you can see what we normally refer to as the 3-line method. So you start with a line that is along the diaphyseal line of the proximal femur. And to find this line, you can either use your joint axes, as in the first X-ray, or you can use the mid-diaphyseal point. Now, having drawn your mid-diaphyseal line, you then move across to the center of rotation of the hip, and you draw a second line that is parallel to the mid-diaphyseal line. You then draw a third line, and this line starts at the center of rotation of the hip, but it has an angle of approximately 7 degrees from your second line. And the reason that we choose 7 degrees is because that is the difference between the anatomical and the mechanical axis. So that third line then represents the mechanical axis of the proximal femur. So there are 2 ways to do it, and you can use whichever one you prefer or whichever one you find easier. If you're planning intramedullary nailing after deformity correction, then it is better to use the anatomical axis rather than the mechanical axis. Now we come to something that's really very important in deformity correction, and that is patient selection. And I would say that this is even more important than the technical aspects, because whether your procedure is a success or not will really depend on how good your patient selection has been. And as we all know, you can do a perfect operation, but the results may be poor if you haven't selected your patient appropriately. So first of all, as I've mentioned, not all deformities require correction, and mild deformities may be accepted, particularly if you are putting the patient at risk of other procedural complications such as infection or non-union. You also have to consider whether correction is in the patient's best interests. So, for example, if you have a type C host, that is a patient with multiple comorbidities, then you have to consider quite carefully whether you should embark upon a challenging course of reconstruction. And every case is different, and so every case must be assessed on its own merits. Now we come to the technical aspects of managing the deformity. So we have selected an appropriate patient, and we have identified the deformity and the bone. Now we are going to think about the technical aspect of correcting that deformity. So the first thing to think about is A, which is the apex of the deformity. And by that, we mean the point around which the deformity has occurred. So when we talk about the apex of the deformity in limb reconstruction, we usually say chora. Chora means the center of rotation of angulation, and it is the center around which, if you correct the deformity, it will return to its anatomical position. So, for example, if you look at this picture, you will see that this is a fracture that has healed, but it is healed with some translation. So when it is healed with translation, there is something that looks as though it may be the apex of the deformity, which is here, which is the obvious apex. However, because the fracture has healed in translation, the true apex of the deformity is not where the obvious bump is. It is somewhere different. And if you were to draw the diaphyseal lines of the distal fragment and of the proximal fragment, you will see that they intersect at a different place. And this is the true apex of the deformity, or the chora. And you can see an example of that. You can see an example of that in the x-rays demonstrated on the right-hand side, where the chora of the deformity is slightly distal to where the bump in the bone is. Now, if we move on to where we're going to make our cuts, which is the level of the osteotomy, there are 3 rules that we need to consider. If you create your osteotomy at the level of the chora, that is known as osteotomy rule 1. So you're going to correct your deformity at the chora itself. And as far as possible, we will try to do this. Now, if you look at the picture on the right, you will see that this is the chora of the deformity, which is the intersection of the diaphyseal lines of the proximal and distal fragments. Now, if you perform an opening wedge, as you see here, then you will create length. If you do a hemi wedge, which is to say that you take a small wedge out of half of the bone and you open up the other half of the bone, that's known as a hemi wedge, that will give you no increase or decrease in length. So it will remain length neutral. And if you were to perform a closing wedge osteotomy, then that will shorten the bone. So depending upon whether the patient is long or short or what you're trying to achieve, you can do either of these 3 cuts. We move on to osteotomy rule 2, and this tends to apply when you have a deformity around a joint. What that means is that you perform your osteotomy in a different place from the chora, but when you do your correction, you are still moving the bone around the chora. So you can see an example here on the right where the chora is at the level of the joint. So technically, it isn't possible to do your osteotomy there, because if you did, you would end up with a very small segment of bone that would be very difficult to stabilize. So you can choose to do your osteotomy distal to the chora so that you have enough bone to stabilize proximally. However, when you do your osteotomy, you are still moving. This is your focal point. So you are still moving around that point, which is the chora. And you can see that you will end up with a secondary translation. And that is acceptable because if you measure your mechanical axis, you will see that you have corrected the mechanical axis, even though the bone may look not straight. You can see another example here where the chora is very close to the knee joint. However, for the same reasons, because you want to get stable fixation of the distal fragment, you do your osteotomy proximal to the chora, but your correction will still happen around the chora. And so when you have finished, the bone will not look straight, but the mechanical axis will be corrected. And the mistake that people commonly make here is that they try to create a straight piece of bone in order to put your fixation. So if you want your plate to sit nicely on the bone, people will correct that translation. But if they correct that translation so that the plate sits nicely on the bone, what will happen is that your mechanical axis will not be corrected. So don't be tempted to do that. Now that's known as osteotomy rule 2. Osteotomy rule 3 is where the bony cut and the chora are not related at all. So you make your bony cut at a different place from the cora, and you also do your correction at a different place from the cora. And that will give you no correction. It will give you a secondary deformity. So this is an iatrogenic problem, and we try to avoid this at all costs. Now, once you have achieved your correction, you need to think about how you're going to do it and how you're going to stabilize it. So are you going to do it acutely or gradually? Are you going to use internal or external fixation? And is your internal fixation going to be intra or extramedullary? There are many reasons to choose each of those options, but that is a decision that you have to come to after discussion with your patient. So this is an example of an acute correction. You can see there that the deformity was corrected and a plate was applied. Now, if you do an acute correction, it's one shot. So you have to get it right first time because you don't have the opportunity to go back and do it again. So you have one shot and you have to get it quite accurate the first time. So technically, it can be challenging. You also have to consider that doing an acute correction is more risky to the soft tissues, especially if you're correcting a big deformity. You can create a problem with the soft tissues. However, obviously, if you do an acute correction and fix it internally, it is more easy for the patient to manage. As opposed to that, you may do a gradual correction, and we would normally use circular fixators to do a gradual correction with, either a hexapod, such as the talar spatial frame, or a standard Ilizarov frame. And we do gradual corrections because it is less risky to the neurovascular structures. So, for example, if you are correcting a valgus deformity, it will stretch the common peroneal nerve, and you may run the risk of getting a foot drop and other problems. Also, if you are correcting a significant deformity, then it's better to do it gradually because there's less risk to the soft tissues. So you can see here an example of a valgus deformity of the distal tibia, and that was corrected gradually with a hexapod frame, and then you can see the final results. A word about oblique plane deformities. If you have a deformity that is visible both on the AP and on the lateral x-rays, as you can see here, so the deformity is visible both in the coronal and in the sagittal planes. That means that you are not seeing the maximum deformity either in the coronal or in the sagittal planes. So the maximum deformity is in neither. It is in a different plane called the oblique plane. And this is purely because conventionally we describe deformities using the coronal and the sagittal planes. But if the maximal deformity is oblique to those planes, then you will see it in both coronal and sagittal images. And that is an indication that the maximum deformity or the apex of the deformity is oblique to those planes. So you just have to be aware of that. However, don't be tempted to say it's two deformities. It's still one deformity, and it still has one cora. If you are measuring your cora and you find that it lies outside the bone, or that the proximal and distal segment axes do not meet, then that is an indication that there is a deformity with multiple cora, or a multi-axial deformity. For further reading on this topic, I have given you some suggestions. Draw Paley's Principles of Deformity Correction is the Bible of deformity correction. However, you may also like to read The Art of Limb Alignment by other authors, and this is slightly easier to read and to understand. And the same authors have also written The Art of Limb Alignment using a talar spatial frame. There are also many online resources. The most useful is the Multiplier app. This is a free app that you can download to your phone, and it gives you the standard measurements. for deformity correction, as well as lots of other useful measurements. And then finally, there is Bone Ninja, which is an app for iPad, which allows you to import X-rays into the app and then do a virtual deformity correction to help with your preoperative planning. I hope this has been useful for you, and thank you once again.